This is Gene Hessel recording the ITE review session on physics, anesthesia delivery system, and monitoring. We have a lot to go over. I'm going to go quite quickly. However, I will supply in Canvas an expanded version of this presentation, which has about twice as many slides and more information for your review. These are the keywords we're going to go over. And these are some of the references I've used. So the first topic was the Clark electrode. This was invented by Leland Clark, professor in Cincinnati in 1953, and it is used to measure pH. Oxygen, excuse me. It is called a polarographic electrode. Has a silver wire electrode and a platinum cathode inside potassium chloride solution separated by a semi-permeable membrane, which produces a small voltage. And what is unique and makes it work is that the amount of current is proportional to the partial pressure of oxygen. So this is a picture of it. You see the cathode and anode. This is inside a solution of potassium chloride, and it's separated from the blood or from whatever solution you're trying to measure the partial pressure in, and based on the voltage produced, it can calculate the partial pressure. Now, as far as arterial blood gases, the machines inside the machine has several electrodes. There's a Clark electrode for measuring the O2, a Shantz electrode for measuring pH, a Severing-House electrode, an anesthesiologist who invented this CO2 electrode. But the rest of the measurements are calculated. The bicarb, the base excess, and the oxygen saturation. Now, most modern blood gas machines have a separate multi-wavelength oximeter, which actually measures saturation. And in the report that you get printed out, it'll show that it's measured rather than calculated. If it's only calculated, then it'll just say calculated. But the partial pressure will change. As the temperature goes down, the partial pressure will go down and vice versa. Now, if you tell the lab what the temperature of the patient was when you obtained the specimen, the lab will report the temperature corrected measurement. Now, the real debate is what should the pH and the PCO2 be during hypothermia? In the old days, we thought that the pH and the PCO2 ought to be the same in the temperature-corrected gas as it is normally. In other words, the temperature-corrected pH should be 7.4 and the temperature-corrected CO2 should be 40. However, in the 1980s, it was discovered or suggested that, in fact, organs work better when they are alkalotic during hypothermia, that cerebral perfusion is more normal, that heart function is better, and so it was proposed that the patient should be alkalotic when they're hypothermic. It just turns out that if the pH and the PCO2 in the gas sample measured at 37 degrees is normal, the corrected pH and pCO2 will be appropriate for that temperature. Now, this was a big hullabaloo about 20 years ago, but in fact, at least for moderate hypothermia down to around 30 degrees, it probably doesn't make any difference. The next topic we were to discuss is the gas laws. And although it wasn't one of the key questions, it's important for you to understand that standard temperature and pressure is 0 degrees and partial pressure of 760 millimeters of mercury. But the gas laws you were asked about are the effect of temperature. And Charles' law says at a constant pressure, the volume will change proportional to temperature. Conversely, at a constant volume, the pressure will change proportional to temperature. The third law you were suggested to know is Dalton's law, and it's fairly important because it states that the total pressure is the sum of all of the partial pressures. And we use this to calculate the concentration of gases in a mixture of gas. If you know the partial pressure of gas, the concentration of the gas is the partial pressure divided by the total pressure, in this case, atmospheric pressure. Or conversely, you can calculate the partial pressure if you know the concentration of the gas. The next topic was the Poiseuille's law. This describes the pressure drop of a fluid or a gas through a tube. And this is their formula. It says the pressure drop is proportional to length and the viscosity and the flow rate and inversely proportional to the fourth power of the radius. Thus, the flow is adversely affected by increased length, increased viscosity, and decreased radius. This is very relevant to the flow through tubes. Remember, red cells increase viscosity and therefore slows the flow of fluids. The second is the effect of radius, and on this slide I've shown the effect of different size catheters, same length, on flow rates. Dramatic change from a 14 gauge to a 24 gauge. And finally, the effect of length. And this is very relevant if you have a short 16 gauge catheter in a vein, there's a good flow. But if you have a 16 gauge catheter that's 16 centimeters long, the flow is 160. Now, in regards to flow, and this is particularly relevant to flow through gas flows. It also applies to liquids through tubes, but it's more relevant to our practice to gas flows. And as you remember, there are two types of flow, laminar flow and turbulent. Laminar flow is smooth, orderly. The particles move in a line parallel to the wall, and the flow is fastest in the center and slowest as you move out towards the wall. Laminar flow follows Poiseuille's law. Importantly, it's influenced by the radius to the fourth power and by viscosity. I emphasize this because it is different with turbulence, and it's linear. I took out the slide, but it's in the Canvas program. If you plot flow versus pressure, it's linear. Turbulent flow is disorderly. The flow are not parallel. The particles move in all directions. And Poiseuille's law does not apply to turbulent flow in two regards. First of all, it's influenced by radius to the fifth power. And secondly, instead of viscosity, it's influenced by density. And this is relevant to our practice in anesthesia when patients have turbulent flow either due to tracheal stenosis or obstruction in the tubing, that helium is useful for two reasons. Mainly, or for the reason that it has a lower density than oxygen. And because density is important in the pressure drop during turbulent flow, helium can improve flow when you have turbulent flow. And as I stated earlier, unlike laminar flow in which the relationship to pressure is linear, with turbulent flow, it's exponential. And the faster the flow, the more the pressure gradient. And that's why when patients have obstruction and they try to breathe rapidly, they have much more problem than if you can convince them to breathe more slowly. The same is true as you're trying to get flow through endotracheal tubes. So turning now to the broad topic of anesthesia delivery systems, or the so-called Anesthesia Work System. We used to call these anesthesia machines, and some people still do, but the proper phase is the Anesthesia Workstation, and it includes many components. The gas supply system, the vaporizers, the circle system, the ventilators, the scavengers, and some of the monitors. And we're going to talk about some of these components in the next few minutes. The first is the source of gases, and as you know, we have sources on our machine. We have pipelines, and in this simplified diagram, we have only two types of gases, nitrous and oxygen. Now, obviously, you know, if we have helium or CO2, there would be other tubes involved. But we're going to talk about the standard machine with nitrous and oxygen. And they're connected to the wall, and the pipelines come into the system here. In addition, we have pipelines, and these are interconnected. Now, the pipeline pressure is about 50 to 55 millimeters of mercury. Both oxygen and nitrous come in at a pressure of around 50 to 55. Now, the pipelines have much higher, the cylinders have much higher pressures. The nitrous cylinder, if it's full, is about 750, and the O2 cylinder, if it's full, has a pressure of about 2,000. Now, if we connected these directly into the system, all of the gas would come from the pipelines. But the engineers put a pressure regulator between the cylinders and the pipelines to reduce this pressure down to about 40 millimeters of mercury. As a consequence, as long as the pipeline pressures are normal, gases will not flow from the cylinders into the system. Now, let's go specifically to the oxygen delivery system. I mentioned that the pipeline for oxygen delivers it at about 50 psi. The cylinders have up to 2,000 psi, but as I already indicated to you, the pressure reduction valves lowers this to 45. And so as long as the pressure in the oxygen pipes is higher than 45 millimeters psi, no gas will come out of the cylinder, even if it's left open. On the other hand, if it is left open and the pressure falls in the pipeline, the cylinders will start to empty. I'm going to talk later about pipeline failure, but we need to digress here about cylinder pressure. When the cylinder pressures fall, the gauge reading will go down. But if the tank is turned off, many of the machines won't show that tank pressure. However, the modern anesthesia machines will typically show the tank pressure, and furthermore, when the pipeline pressures fall, it will alarm. Now, another key word is cylinder, E-cylinders and what's in them. I've listed on this table CO2, air, helium, and heliox, but the only ones for our cylinders that you need to be concerned about is oxygen and nitrous oxide. I don't think they're putting air cylinders on our machines anymore, but I could be mistaken. Anyway, so in America, the oxygen cylinders are green. In Europe, oxygen is white, and nitrous oxide is blue. Now, a full cylinder of oxygen has 2200 psi and contains about 625 liters, and a full nitrous cylinder has a pressure of 745 and a volume of about 1600. Although I passed over it, air in the U.S. is colored yellow. In Europe, it's black and white because it's oxygen and nitrogen. Anyway, the air cylinder, if full, has about 2,000 cc's, just like oxygen, and has a similar volume, about 500 cc's. Now, what about the volume in a cylinder? If the gas is in a gaseous state, and this is true of air, of oxygen, and air, and helium, and heliox, but the ones we're concerned about here are oxygen and air, the content is directly proportional to the pressure in the tank. Conversely, the volume in the tank is proportional to the pressure. On the other hand, if the cylinder is in the liquid state, and this is true of nitrous, the content is not proportional to the pressure in the tank until all of the gas in the tank is in the gaseous form. In other words, all the liquid is removed. And for nitrous, about 3/4 of the volume has to be removed before all of the liquid is now in the gas phase. So, to put this in perspective, with an oxygen cylinder, when it's full, it contains 600 liters and has a pressure of 2200. And as the oxygen is removed, the pressure will fall. When the pressure is half, it has half as much volume. When the pressure is a quarter, 500 psi, it has about 150 liters. As far as a nitrous cylinder, I've already explained that when it's full, it contains 1600 liters at a pressure of 745, but the pressure will not fall until only about 250 liters of nitrous is left in the tank. Now, another topic is what to do about pipeline failure. As I mentioned, if the oxygen cylinders are turned off, the oxygen pressure in the machine will not fall, and in older machines, alarms will not. I'm sorry, I'm upside down here. If the oxygen cylinders are turned off, the oxygen pressure in the machine will fall and the alarms will sound. On the other hand, if the oxygen cylinders are not turned off, they will automatically feed pressure into the machine, and in older machines, the alarms will be suppressed and you won't know about it until now the cylinders are empty and the pipelines are empty. Now, the newer machines, I think, alarm whenever the line pressure falls, but be alert to that problem. Also note that there are alarms in the room when the room loses oxygen, and you should pay attention to that. Everyone ignores those alarms, but you should. Now, this just shows what this is all about. There's an alarm here that notices when the pressure going to the vaporizers goes below 12 psi. And if you lose the pipeline pressure very rapidly, this pressure will go below 12 and the alarms will go off. But as I mentioned, if the CO2 cylinders are left open, they will deliver 45 millimeters, PSI, and the alarm will not go off until the oxygen cylinders are empty. I've probably belabored that too much, but anyway, important. Now, what do you do when you lose pipeline oxygen? The first is to open up the oxygen cylinder. Secondly, you should do everything you can to reduce the use of oxygen. One is to go to hand ventilation, because some of the machines use oxygen to drive their ventilators. That isn't true of our modern piston ventilators, but if you're using a ventilator that uses a bellows, some of the machines use oxygen to drive the bellows. You can reduce fresh gas flow, and remember to turn off the auxiliary oxygen supply flow meters. Sometimes those are left on, and they're draining oxygen from the system. And finally, make sure that there are extra oxygen tanks in the room while people are trying to figure out why the supply of oxygen to the room is discontinued. By the way, this is part of the ASA clinical checklist. Before you start a case every day, you should make sure there's an extra E-cylinder in the room so that if the one on your machine wears out, you have a spare. And finally, notify people that you have a problem. So let me turn to the circle system. In the old days, you were challenged, and I think they may still ask a few questions about the Mapleson circuit, but we only use on our machines circle system. The features are it has 3 valves, an inspiratory valve, an expiratory valve, and a pop-off valve. There's a CO2 absorber, and there's a reservoir bag. And it can provide total rebreathing of expired gases, but not of CO2. And it can be operated in a fully open system, or semi-closed system, or a closed system. So it's very ubiquitous. This is a diagram of it. Sometimes they ask questions about the key components. This is a CO2 canister. This is the exit from the CO2 canister headed out of the machine. We have our inhalation valve, and then the tubing that goes to the patient, the Y piece, the tubing that comes back, the expiratory valve, and then it goes back to the CO2 canister. Now, tied in at the end here, just before the CO2 canister, is this T connector, which connects either to the ventilator or to the reservoir bag. And at this location is the APL valve, which determines how much pressure we're generating when we're squeezing on the bag. All of this system should be at the end of the circuit, just before the CO2 canister, and the fresh gas flow should come into the system right after the fresh gas leaves the CO2 canister. Now, with the circle system, rebreathing of CO2 is prevented by the CO2 absorber. But importantly, the amount of rebreathing of expired gases depends on the fresh gas flow. When the fresh gas flow is more than the minute ventilation, in other words, if the minute ventilation is 5 liters and the fresh gas flow is 5 liters, there is no rebreathing of the expired gases as long as the valves, the inspiratory and expiratory valves, are working properly. But as the fresh gas flow reduces, more and more of what the patient breathes is their expired gases. And of course, their expired gases have both the oxygen and the anesthetic vapors removed from them. And so what the patient gets is no longer directly related to what you're dialing in, but how much they're rebreathing expired gases. In this set, it's in the set that's on canvas. The problem with soda lime is it produces strong bases, and these are the causes of some of the fires that are seen with overuse of soda lime, and also some of the chemical activities that causes abnormalities with inhalation agents. And so that's why these other agents are popular, because they don't produce strong bases. But they're more expensive, and they're not what we use. But you should be familiar about the pros and cons. A few words about the toxicity of volatile agents related to CO2 absorbance. And I think there's another, I said Dr. Schell reviewed this. This is from last year's presentation, and I'm not sure who is giving the presentation on inhalation agents, but I believe, and maybe you've already had that, there is quite a review of the toxicity. And I'm just going to brush over this rapidly for review. Sevoflurane has some problems. One is, especially with berylline, it could get very hot and cause fires. And that's really why berylline disappeared. Another problem, potential theoretic problem, is that when sevoflurane reacts with CO2 absorbance, it can produce compound A. I can't even read this, but you can, or say it. I can read it. And anyway, this is compound A. And the concern is that it may be a renal toxin. Apparently in rats, evidence that it's toxic to humans is virtually absent, but it's for this reason that another reason why people avoided soda lime, because the other agents tend not to produce compound A, the other absorbents. And secondly, because of this theoretic concern is why the FDA says that for the first 2 MAC hours, you need to have at least 1-liter flow, and thereafter you have to have 2-liter flow, which makes sevoflurane more expensive than our other agents. The other concern is this generation of carbon monoxide, again characteristic of soda lime and not of the other agents. And what's noticeable is the worst agent for this is desflurane. It was worse with berylime, but it's also a problem with soda lime. The real problem is if the absorbent gets dry. And for this reason, this phenomenon called the Monday morning syndrome was reported. These were patients that were found to get high levels of carbon monoxide when anesthetized as the first case on Monday morning. And on analyzing it, it was thought it was due to desiccation of the absorbent when the fresh gas flow was left on over the weekend, which caused drying of the absorbent. And so that was a real problem. We now, the techs are very careful of making sure the machines have no fresh gas flow. But however, if you come in the morning and you see the fresh gas flow is still on and you plan to use a desflurane, I recommend that you have them change the CO2 canister. Now, what to do about soda lime exhaustion? This was a key word. The diagnosis is made when you see the inspired concentration going up, and I've already talked about what to do about it, so we'll move on. The next key word was vaporizers, and there are several sections in this part. This is often confusing to residents, but the textbooks are very thorough on this, and the Canvas PowerPoint that I've made available to you also has a lot about this. So the underlying principle is that all of our potent anesthetic agents, volatile agents, are liquid at room temperature. But at equilibrium, there is always some vapor in the atmosphere above the liquid. And the amount of vapor in that atmosphere depends on the agent and the temperature. And the concentration is of the agent is given by the vapor pressure of the agent divided by the total barometric pressure. Now on this slide, I've shown our 3 most commonly used potent agents nowadays, and it shows their vapor pressure and the concentration of the vapor sitting above the agent. And the relevance of this to vaporizers will become apparent in a few moments. For isoflurane, the vapor pressure is about 240 millimeters of mercury, and hence the concentration of isoflurane in the vapor sitting above the liquid is 31%. For sevoflurane, the vapor pressure is about 160, and the concentration above the vapor liquid is 21%. Desflurane is unique in that the vapor pressure is very high, almost 664 millimeters of mercury, and the concentration of the vapor above the liquid is almost 90%. Now, what our vaporizers use is to combine this vapor sitting above the agent with the fresh gas flow to generate the appropriate concentration. And there are basically 3 types of vaporizers that the key words emphasize. One is the conventional vaporizers, the second the desk flame vaporizer, and the third the Datex cassette vaporizer. And we'll talk about these now. The Tech vaporizers, which are currently used for sevoflurane and isoflurane, but in the past were used for halothane and enflurane and all the other halogenated agents, are described as variable bypass, flow over wick, temperature compensated, agent specific, out of system vaporizers. And this is a diagram of how these work. This is the vaporizer here. The fresh gas flow comes in from the left side, and some of it is diverted through the vaporizing chamber. In the bottom of the vaporizer is the liquid, and there's a wick here which facilitates the liquid becoming mixed and forming saturated vapor. This vapor has the same concentration that we just reviewed, 30% for isoflurane, 20% for sevo, 90% for desflurane. This then goes back and joins the remainder of the fresh gas flow. And how much is diverted determines how much agent is being added, and hence the concentration being delivered. These are also temperature compensated, so that within reasonable room temperature they still produce the proper amount of vapor. The second vaporizer is the desflurane vaporizer. Now, because of the characteristics of desflurane, they could not use conventional Tech vaporizers that we've just described. This is because they would have to have very high bypass flows, and the high rate of vaporization would cause substantial cooling, and likely it would boil when the ambient temperature was very high. Therefore, they had to develop an entirely new vaporizer, and it's described as an electrically heated, thermostatically controlled, constant temperature pressure, electromechanically coupled, dual circuit vaporizer. It has a separate vaporizer chamber and a separate fresh gas flow. The vaporizer chamber is electrically heated and pressurized to a temperature of 39 degrees and a pressure of 1,500 millimeters of mercury. And the vapor pressure inside that is 1,300. It's pure, I'm sorry, the pressure is 1,300, and it's only made up of desflurane. And this is how it works. The fresh gas flow comes in through a separate circuit. In addition, there is a separate vaporizing chamber. It only contains desflurane, which is heated to 39 degrees, and so what comes out of this is pure desflurane at a pressure of 1,400 millimeters of mercury. By intricate electronic monitoring of the fresh gas flow and the pressure, there are control knobs that determine how much of this concentrated vapor should be added to the fresh gas flow to generate the proper concentration of the agent. Very intricate, but very accurate. In addition, since it was a newer development, they were able to add some additional bells and whistles. And it has automatic shutoff, unlike the other vaporizers. If the fluid level is low, if it's been tilted, if there's power failure, and if the chamber pressures aren't appropriate. and alarms will sound as well. The third vaporizer is the so-called cassette Datex Almeida Aladdin. This is very similar to the older Tech vaporizers with the two circuits. However, it is controlled by a computer. And this is a diagram of it. It looks very similar to the Tech vaporizer. There's inflow, and some of the gas is diverted to the vaporizer chamber, and then it is mixed with the fresh gas flow to generate the proper concentration. What is unique is when you plug the cassette in, and there are separate cassettes for each type of vapor, each type of anesthetic agent. When you plug it in, the computer recognizes what vapor there is. It also measures the temperature and measures the pressure in the chamber and does all the calculations to adjust the valves so that it generates the proper output. So it's similar to the Tech vaporizer, but it's controlled by a computer. As I say, the computer receives all of this information, and based on that information, it produces the proper concentration of agent in the fresh gas flow. I guess I explained that better on this slide. Descending vaporizer will deliver a constant percent, but less MAC, and a Tech vaporizer will deliver a lower percent, the same partial pressure, but a higher percent, the same MAC. A few words about some of the hazards of vaporizers. One is tipping, overfilling, underfilling, leaks. I mentioned one of the advantages of the Descending vaporizer is it's designed to not be bothered by tipping or overfilling. Most of our modern vaporizers are temperature corrected, so you don't have to worry about it. They're also insensitive to flow, except extremes. But between a quarter of a liter a minute and 10 liters a minute, they're very constant. One thing that a lot of people don't appreciate is that carrier gas does affect the performance of vaporizers. And nitrous oxide will reduce the vapor pressure, and at low flows, nitrous oxide will lower the output of the Descending vaporizer. Now, one thing that is important, and this is a key word, is what's the effect of giving the wrong agent. And if you understand the vapor pressures of the two drugs that we might mix up, that would be isoflurane and sevoflurane. If you put sevoflurane into isoflurane vaporizer, it thinks it's giving sevoflurane, it thinks it's giving something with a vapor pressure of 225. Instead, it's only delivering a vapor pressure of 175, so it'll give you a false low value. Conversely, if you put isoflurane into a sevoflurane vaporizer, it thinks it's having a low vapor pressure, but it has a high vapor pressure, so it'll deliver too much of the agent, so and vice versa. So there you go. So the next big topic is anesthesia ventilators, and there are various issues about this. But on this slide, I've talked about classification. One is a type of reservoir. Is it a bellows? Is it a piston? Or is it a volume reflector? And the second is, what is the power source? Is it compressed gas or electric or both? And the third is, what is the driving mechanism? The old days, the most common was pneumatic, so-called double circuit or bellows. We're going to talk more about it. But our next generation used pistons. And the one we use at the moment, the newer Draeger machine, uses a turbine. There is another system made by Maquette, but we don't use that. There's also different modes of ventilation cycling, and that's beyond our topic. So this is just an illustration of the bellows, the so-called ascending bellows and descending bellows. And the piston, which is pretty simple, it just goes up and down and moves the volume inside here. And I don't have a picture of the turbine, but it's just a turbine that generates the force going into the lungs. So in the old days, and it's not too relevant anymore, but you will see them every so often, is the Bellows ventilator. It's sometimes called a double circuit, a bag in a box. So gas pressurizes the box, and this causes the bellows to move. The driving gas in the old Maida machine is oxygen, and in the Draeger machines was a combination of air and oxygen. There's a big controversy about ascending versus descending bellows. In the old days, we used the descending bellows. The bellows was attached to the top of the box, and it was weighted, and it would fall during exhalation and go up during inspiration. The ascending bellows is just the opposite. The bellows is attached to the bottom of the box. It ascends during exhalation and descends during inspiration. The older machines used descending bellows. Most of the newer machines used ascending bellows, although apparently some machines were using the other. Now the problem is about safety, and in general, the descending bellows had some problems. First of all, if you have a disconnect, they'll still fill. Secondly, if you have a partial circuit leak, they will fill up with ambient air. And so there were real problems with this, and this is why people have pretty well gone to ascending bellows when you use a bellows system. Now, a minor comment, but it brings up a key word that was brought up, is what happens when you change the fresh gas flow on the tidal volume that the patient receives from an anesthesia ventilator. And the old days, anesthesia ventilators, during inspiration, the system was closed. That's the only way it would work. And so when the system was closed, any fresh gas flow that was coming into the system would be added to the tidal volume coming from the ventilator. And so if you had a high fresh gas flow, they'd get a lot of tidal volume. And conversely, if you lowered the fresh gas flow, they would get less tidal volume. And that made anesthesiologists have to pay a lot of attention to the impact of fresh gas flow on how much the patients were getting from the ventilator. Well, in the last few years, that has been resolved by the manufacturers by two methods. One method was to monitor the exhaled volume and the inhaled volume. And you know, our machines all have monitors, and they measure the inspiratory volume and expiratory volume. And what the machines do is then adjust how much volume the ventilator is delivered so that the volume delivered to the patient is what you dial in. The other method is called fresh gas decoupling, and I only bring this up because it's a key word. And only a few machines use it, but anyway, here. So it's on our Narcomed machines, and this is called fresh gas decoupling. You can note this on our machine if you pay attention, because you notice that during inspiration, the bag expands. That's because the fresh gas flow is coming into the bag during inspiration. Another topic is a scavenger system. We are required to scavenge all vapors because of the theoretic but unproven concern about exposure to inhaled agents. So the ASA says we must scavenge fresh gas flows. We must scavenge anesthetic gases. Now, where can they come from? They can come from the APL valve, they can come from the ventilator, they can come from gas sampling, they can come from the fresh gas drive of the machine, leaks, and from off of masks and uncuffed tubes, and well, you fill vaporizers. So you have to think about all these places that are sources of gases that we ought to get rid of. Now, on the canvas, I've gone into various types. I have pictures of those. But they're basically two systems: an active system, which has a suction and vacuum, and a passive system, which opens it to the atmosphere. In this case, the roof of our building. And remember that scavenging can be facilitated by low fresh gas flows, and also changing the room, the air in the rooms rapidly, and that's determined by our maintenance department. There are problems with these scavenger systems. It's in your checklist to check that they're working. If the positive pressure system isn't working properly, to pop off if the negative pressure is too high, and if it's not connected to the vacuum system in the hospital. A word about safety system. ASA says we need to monitor for disconnect. There are many ways to do this. Machines are required to have an alarm. Some use tidal volume, some use minute ventilation, some use peak airway pressure. But I've already told you all on occasion that capnography is one of our best clues to ventilator disconnect. There are a number of alarms on the machines: the apnea alarm, disconnect alarm, FR2 alarms. I always emphasize that they have to be activated, they should be sensitive, and they should display, typo here, should be displayed by lights, written messages, and sound. There's the auction fail-safe system, which I'm going to show. There's the nitrous oxygen ratio system, which isn't a keyword this year, so I didn't show the pictures, but it is in the canvas display. I will show the oxygen fail-safe system on the machine, and we'll talk about the PIS and DIS. So this is the oxygen fail-safe system on the machine. It's connected to the pipelines going to the vaporizers, and it's sensitive to pressure of around 45 millimeters of mercury. I'm sorry, excuse me, I'm pointing to the wrong thing. This is the alarm system, and when the pressure goes below 14 to 35 millimeters of mercury, this alarm system sounds off. and it'll sound off when it prevents any nitrous from coming into the system if there's no oxygen. So I guess I should go back over this. This is designed so that if the oxygen fails and the nitrogen is still on, this pressure fail-safe will turn off when the oxygen pressure line, which it's sensing here, goes below 50, and will prevent any nitrous from getting into the system. So this valve here, as you see, is connected to the oxygen pipeline and to the nitrous pipeline. And when the pressure in the oxygen pipeline goes to 0, this valve is closed and it stops any nitrous from getting into the system. I sort of fumbled my description. I'm sorry about that. The problem with this system, of course, is if you knock off these pins, either maliciously or by accident, you could then put any tank on there. So read the labels. The disc system is designed to protect the connection of the lines that come from the wall and are connected to the anesthesia machine. And these are mated, the bolt connected to the line and the receptacle on the anesthesia machine. And this shows them on the back of the machine. They're also color-coded, and the shape and diameter of these connectors are different. Now at the other end, there is a special connector that goes into the wall. This is not the disc system, but again, these are unique to each agent so that you can't plug the wrong cord into the wrong thing. Of course, if someone puts the wrong connectors on the wrong tube, it could be a problem. And talk about another key word, which is line isolation monitor, and I've provided you here some references which I found very helpful. It says there's a leak in the system, and there is still risk of microshock, but no risk of macroshock. All of the equipment will work. However, when this alarm goes off, people in the room should try to find out what is the offending equipment and take it out of service as long as it's no longer required. Sometimes it just means getting rid of too many pieces of equipment. And of course, heaters, warming blankets, all of those things tend to use a lot of energy and cause a lot of leaks. So I emphasize that they are not designed to prevent microshock, and this may be a question that is brought up from time to time. And by microshock, we mean what you can get low intensity, less than 100 microamps, which you can get if you connect a system that has a small leak to a wire that's connected to the patient, such as a pacemaking wire or a pulmonary artery catheter or any other things that are in contact inside the patient rather than protected by the patient's skin. So line isolation monitors don't protect you from microshock, but they're important that you understand a little bit about them. Moving now to monitoring. The question really is about arterial pressure monitoring. This is historical of different methods. You know that nowadays we use oscillometry. You should be familiar with that. And of course, for patients that have LVADs, we often use Doppler assessment of the radial. And we do have the new kid on the block, the finger cuff, and I'll mention that. It rates the pressure. So pressure is simultaneously applied to the cuff, and the oscillations in the cuff are analyzed by the machine. The machine generates a high pressure and gradually lowers the pressure until it starts to see the oscillations. As it does, the oscillations get larger and larger, and then they get smaller and smaller. When the oscillations start, it calls that systolic pressure. When it's maximal, it calls it mean pressure, and when it's minimized, it calls it diastolic pressure. A few criteria I have here about what's important about using oscillometry as far as cuff size and where the bladder is. The other method that you've all used, I suspect, is this finger cuff method, available on our Edwards monitor, and it will also measure non-invasive blood pressure. And furthermore, we'll show you a trace. It looks just like an arterial line. Not quite as good, but pretty good. Now, one of the key words was a reference location for arterial pressure. And that's because of the effect of gravity. The pressure within columns of fluid, such as the blood within the arteries, varies with vertical elevation. When the patient is level and the transducer is the same level, the pressures everywhere are the same. But when the patient isn't level, the pressures aren't the same. A common position that our patient is in the back up position. The back is elevated about 30 degrees. The head is about 30 centimeters above the heart and the arm where blood pressure cuffs are. And because of the gravity, the pressure in the head is about 20 millimeters lower than the pressure in the heart. For this reason, when the pressure is not level, the transducer should be at the level of the organ you're most interested in, and I hope you're most interested in the brain. And so the transducer should be at the head level. And conversely, if you're measuring the pressure at the arm level, you should consider that the head pressure is about 20 millimeters lower than the pressure in the arm. A key word, and I don't know why it's a key word and how important it is, but it's there. And I even had to review this myself. But fortunately, there's open anesthesia, and they answer this keyword. So take a moment and read the difference between the arterial waveform as it goes from center to periphery. The arterial upstroke becomes steeper, the peak becomes higher, the dichrotic notch appears later, the diastolic wave is more prominent, the systolic pressure is higher, the diastolic pressure is lower, and the pulse pressure is wider. Finally, there's a delay. And they specifically say the delay between the aorta and the radial artery is about 60 microseconds, about a tenth of a second. And despite these morphologic changes, the mean arterial pressure in the aorta is always slightly greater than the mean arterial pressure in the radial artery. But it's trivial except in adverse conditions. Another key word was the time constant. This is esoteric, but it has some practical applications. It describes the behavior of an exponential equation. When one introduces a concentration of a substance into a compartment, in other words, inject an IV med into the bloodstream, or start an IV infusion into the blood, or add a volatile agent into the circuit, or fresh gas flow into the lung, or anesthetic agent into the brain, the concentration, the end concentration, equilibrium isn't reached immediately. If you put 1% isophorine into the circuit, it doesn't immediately get into the lungs, and it doesn't immediately get into the heart, brain, and immediately into other organs. The same is true as you change the fresh gas flow into the circuit. So it doesn't occur immediately, but it follows an exponential first-order kinetics given by this formula. And notice there's an exponential here, which is either tau, the time constant, or tau. Tau is the time constant, and it's the volume of the compartment divided by the flow into the compartment. And this is the time it takes to achieve about 63% of equilibrium. It can be related to half time, and this is the formula if you're interested in it. So this shows the course when you start adding a drug to the blood or adding an inhalation agent to the circuit. How long does it take to the concentration that you add, let's say it's 1%, to reach 100% or 1%, to reach 100% of the dialed concentration? In one time constant, it reaches 63%. In two time constants, 63% of the difference, which is now 85%. In three, 95%. And in four time constants, it's almost the same as your initial dialed in. And this shows how fast, when you dial in an agent, it reaches the circuit. And if the circuit volume is 5 liters and the fresh gas flow is 5 liters, the time constant is 1 minute. So if you add 1% isophorine to the circuit, it will equilibrate in the circuit in about 3 minutes. It also tells you how fast the blood concentration equilibrates into the tissue. The time constant for volatile agents in the brain is about 2 to 3 minutes. So it takes about 8 to 12 minutes to reach the end-tidal concentration. The time constant for the muscle is about 1.5 hours, so it takes about 5 or 6 hours for the muscles to be fully saturated. And the time constant for fat is about a day to a day and a half. And so it takes about 3 to 6 days to fully saturate the fat. Near the end is the concept of volume responsiveness. This refers to the fact of will the patient improve their cardiac output when you give a volume bolus. Conventionally, it's defined as an increase in cardiac output or stroke volume when you give a rapid fluid challenge. But there's no agreement on what these parameters are. Typically, it's defined as an increase in cardiac output of 10 to 15%. And typically, a colloid or crystalloid is administered about 250 to 500 cc's over about 5 to 15 minutes. But you have to be careful when you read the literature because each of the studies use different parameters and different volumes and different fluids. Now, I'm not going to dwell on this slide. You can read it, my reservations about the concept. Basically, that just because a patient's fluid responsive doesn't mean they need fluid. So in the past, we used static measures to assess fluid responsiveness. CVP, pulmonary wedge pressure, echocardiography. It turns out none of these are very reliable. And so the trend now, as you know, is to use dynamic indices. The response to a fluid bolus and the effect of ventilation on pressure. I left off a few things here. Limitations. One is it's perhaps not reliable during one lung ventilation, and there's some question during laparoscopic surgery. So there are lots of limitations of this method, but under ideal circumstances, it's. So the next to last topic is awareness, and one subtopic was equipment issues, and there are lots of ways that equipment can fail and contribute to awareness. One is if you have leaks of the agent. Secondly, if the ventilator is entrapping air. And the third is if the vaporizer isn't putting out. I had a case about 20 years ago here, before we had monitoring. And I walked in because I was called by the resident because the patient was, the resident thought the patient was having a seizure. The patient was moving. The reason was the vaporizer was empty and the patient wasn't getting any agent. And unfortunately, the patient did have recall. I know the patient well. I've given her anesthesia subsequently on several occasions, but it's a disturbing thing. And we have just be aware of it. With TIVA, there's a problem with the infusion pumps if it's disconnected and if it extravasates. The key is agent monitoring, depth of anesthesia monitoring. Important to realize that vital signs are not reliable. And then ways of preventing these equipment problems is pre-op machine checkup, vigilance, and monitoring that the agent is being delivered. Now, a general article which I strongly recommend to you, I reviewed it in preparation for this presentation because it was just published recently, a British Journal of Anesthesia Education Journal, and it really is very informative. And I've highlighted some of the things from this article. The incidence is somewhere between 10th and 2%. It's best detected by a formal Bryce interview. You should be familiar with that. And furthermore, awareness without recall is probably 2 to 3 times more common than recall. The significance of this is unknown. Patients don't know they have recall, but under hypnosis and other mechanisms, it can be detected. And it may have subtle effects that we don't know about. Maybe this is why people are scared of doctors or don't want an anesthetic or this, that, or the other. Who knows? Or maybe why children have nightmares. We don't know. The significance is that if they have awareness, recall awareness, about 40% of these patients experience post-traumatic stress syndrome. And yet, importantly, in studies of awareness in anesthesia, 2/3 or more are thought to be preventable. On this slide, I've listed, and this was a key word, some of the risk factors. One is a type of surgery. It's more common in OB, more common in CT, more common in trauma. A little more common in women, a little more common in obese patients. Suggestion that prior substance abuse or current substance abuse may be a risk factor. More common with TIVA. More common with use of neuromuscular blockade monitoring, perhaps because you lose an important symptom. And finally, commonly associated with failure to monitor and reverse neuromuscular blocking agents. So there are things we can do about it. Prevention, be aware of risk factors. Provide adequate depth of anesthesia. Monitor depth of anesthesia like BIS-like devices, end-tidal agent monitoring. Remember, end-tidal agent isn't available for TIVA, so I always use BIS and TIVA. I know not everyone does, but we don't have very good endpoints for adequacy of TIVA. And we had not long ago a patient who had recall during TIVA. Minimize use of neuromuscular blockade agent. Some suggest prophylactic benzodiazepine. This is a crutch. I think experts don't recommend using this as an excuse for all these other methods, but perhaps when in doubt, it might be useful. Of course, it's really bad for old people. And finally, management, and the most important is to acknowledge it. To deny it to the patient is going to cause problems. Accept the fact that they had it. That doesn't mean you have to accept blame. You can say, I'm sorry this experience, and discuss what they heard. Take a careful history. Find out exactly what it was. Risk management needs to be notified because this may lead to problems. Offer them the recognition that this usually is benign but can cause problems, and offer psychological, professional psychology. We have consultants here. We had a patient that we presented at Case Discussion Conference a couple of years ago that had this, and we did go through all of this process. It was a trauma patient. We know why they had recall, because they couldn't receive much anesthetic at one time. They were very hypotensive. The patient had clear recall. We talked to the patient. It was a teenager, I think, and her parents, and offered help. She was very comfortable and decided they didn't need any psychological help. But anyway, seek the cause and recommend psychiatric consultation. The final thing really threw me off because I don't know much about math or chemistry. So I had to study for this. I hope it helps you. Thanks to the internet. So this is what the Henderson-Hesselbach equation is. There's a little history. Wikipedia is wonderful. Henderson derived an equation to calculate hydrogen ion concentration in a buffer solution, and this was the equation, and then it was modified to take into account CO2 instead of CO2 concentration. And then a year later, a guy named Sorensen, I guess it's Peter Lorenz Sorensen, introduced pH terminology. And so Hesselbach jumped on this and rearranged his equation to include logarithms, and this became the so-called Henderson-Hesselbach equation. And they sort of Hesselbach and Sorensen sort of got lost. Anyway, so this is the equation. And I guess, so there's one key word that no one knows the answer to, and they take the test, and this is one you could throw out. The other key word was logarithms and Henderson-Hesselbach. And if you're still here, thank you for staying on. I'll try to clean up that section on the vaporizers that I screwed up. Thank you very much. And that's all I know about algorithm.